During the pandemic, there have been several voices online adding their 2 cents or trying to explain the data in ways that the general population can make sense of. And among this sea of communicators, I can understand how it might be difficult to identify communicators who have good takes and deliver good information versus those who deliver bad takes and misguided information. Of course, I do my best to deliver evidence-based messaging and include all of the data and information that I talk about in my videos in links in the description below so that you can read the primary research and try to understand it for yourself and see if what I say checks out. But sometimes some of you will ask me about other communicators and whether or not they are putting out good information and good messages. One person I've been asked to cover a lot recently is Dr. Vinay Prasad. Vinay is an MD and Masters of Public Health who works as a professor at UCSF. But through the pandemic, he, on his YouTube channel and podcasts, has been promoting questionable ideas. That's not to say everything he said has been wrong or questionable, but he has said a lot of things that are questionable. But similar to people like John Campbell, on his YouTube channel, he gives this vibe that he knows what he's talking about and that he's talking about the real science while others are not. The truth is that he's misrepresenting science a lot of the time, and it can be difficult to identify that. So in this video, I'm going to go over some of the recent things he said about some recent studies, and hopefully you'll get an idea of how honest he is. Hey, I'm Dr. Wilson. I'm a PhD molecular biologist, and welcome to the final day of debunking week. So I already kind of said this, but just to get right to the answer of the title of this video, is Vinay Prasad reasonable? In my opinion, no. The main reason being that there are much better epidemiologists who are going to more honestly and accurately describe the data being published. And while Vinay Prasad is not necessarily one of the crazies, not one of the anti-vaxxers that I cover a lot on this channel, like RFK Jr. or Del Bigtree or Steve Kirsch, he does get endorsements from those people quite a bit, which is not a good sign. But anyway, let's jump into the science. So I was originally going to make this video about Dr. Vinay Prasad's video on this study of 99 million people, but recently he has made comments about a similar study on 46 million people in the UK. So let's start with a study of 99 million people using data from the Global Vaccine Data Network, which uses multiple linked healthcare databases that records things like vaccination status and significant health events, which let the researchers here look at an absolutely massive population that can allow them to detect extremely rare events. And what this paper essentially found was, first, it confirms what we already know. It confirms that the adenovirus vector vaccines from AstraZeneca and Johnson & Johnson did have a rare case of blood clotting. Again, this is nothing new. Several studies have demonstrated this as well, and this was known very early on in 2021. It also confirms that mRNA vaccines did have a rare risk of myocarditis and pericarditis. This is nice because these two things acted as kind of internal controls, where if this data set didn't detect them, then we'd know that there's probably a big problem with the data set. But they did, so that's good. It's working as expected. The researchers also tested for a bunch of other health outcomes, and most of them had no signal at all. However, there were a few adverse events that were newly measured in this study that hadn't shown up before. In particular, they measured an increased risk of acute disseminated encephalomyelitis following the Moderna vaccine. The authors explained that this finding is not necessarily causal. In other words, the vaccines aren't necessarily causing this increase, but it is a signal that they identified in this huge data set that could be followed up on. Overall, this study did show that the COVID vaccines maintain a good safety profile. Just to give you an idea of how rare these events are, one of the more dangerous and more common adverse events following the AstraZeneca and J&J vaccines was CVST, or cerebral venous sinus thrombosis. This is, again, a form of blood clotting. And the rate of this adverse event was 2.5 events per 100,000 doses, which is pretty rare. And several other papers in the literature that have measured adverse health events following COVID-19 show that COVID-19 does indeed carry much greater risk than the vaccines themselves. So that's essentially what this paper added. It was a massive data set that was able to confirm what we already know and point to some other signals that could possibly be investigated, while also showing that the vaccines do have a generally good safety profile because no huge signals emerged out of this massive data set. But Vinay Prasad did not think of it that way. He had some harsh criticism for the paper, and since I'm not an epidemiologist by trade, I figured the words of an epidemiologist might carry more weight in this video. So I contacted one of the lead authors of this paper, Anders Havid, and asked for his opinion on Prasad's comments. So here are his thoughts. In his video, Vinay said that the study suggests that the harms of vaccination in younger age groups outweigh the benefits. To which Anders replied, "Our study doesn't provide benefit-risk analyses, so I guess this comes down to Dr. Prasad's gut feeling. What we see in our study is a number of safety signals primarily for the first doses of both the mRNA vaccines and the AstraZeneca vaccine. It's important to be precise in scientific discourse. Are we talking about benefit-risk for the primary course back in 2021, or are we talking about the coming 2024-25 season? I think there is support for the benefits of vaccinating adolescents and younger adults back in 2021. Next thing that Vinay said was that the electronic health records used for the study are a, quote, piece of and thus this is a significant undercount of adverse events. And Anders replied, I am not concerned about undercounting the serious adverse events that we are looking at. Clinically relevant serious disease will be handled in hospital and assigned diagnostic codes. For many of the outcomes, the validity of the codes has been evaluated previously in terms of positive predictive value, sensitivity, etc. For outcomes such as myocarditis, you could even imagine that there is likely to be overcounting of less clinically severe cases after vaccination due to the publicity around the association with mRNA vaccines. This is actually true. I haven't gotten to the 46 million person study in the UK yet, but they do have a graph in the supplemental figure that shows the rates of myocarditis associated with mRNA vaccines before and after the CDC announcement of the association. And it shows that the announcement does cause the reports to jump up. But anyway, the next thing that Vinay says is that the paper is, quote, cheating by not stratifying risk by age, to which Anders says, our study was primarily a signal generation study based on a relative risk measure that was adjusted for sex and age. We still identify old adverse events and spot new signals. We have already published extensively on selected outcomes, such as on myocarditis, e.g. a study of 23 million people, where we provide relative and absolute risk stratified on sex and age. However, outcomes such as transverse myelitis and ADEM are much rarer, and sex and age stratification is not feasible. Also bear in mind that we are doing a meta-analysis of country-specific results. Thus, we may not be able to estimate the association for all sex and age strata in all countries. This will lead to an overestimation of the combined effect in those sex and age strata that are missing contributions from some countries due to the rare nature of some of these events. So in other words, he's explaining that what Vinay Prasad is complaining about is not the point of his paper. And then he goes on to say that risk stratification by sex and age for the rarest events that they detected a signal for is not really possible because they're so rare. That's because with events this rare, if you continue to stratify them, meaning you break the groups that you have into smaller groups based on sex and age, then those smaller groups are going to be too small to gather any meaningful statistically significant evidence from. So getting to the last comment here, where Vinay says that not including seroprevalence in a risk comparison is, quote, brain-dead epidemiology. Just to explain what Vinay is saying here, he's asking for seroprevalence data, which is antibody data. Basically, it's surveying a population by taking a blood sample and asking, do they have COVID antibodies? The results of this test should imply whether they have or have not been infected by SARS-CoV-2. And here's the reply from Anders. I guess this must relate to the risk of these outcomes post-infection. It is correct that the absolute risk associated with infection will be overestimated in most settings when using PCR positives in the denominator. This is more of an issue with the US with limited testing. In Denmark, where we had universal testing for a period, this approach based on nationwide register data would yield better estimates, at least in the pre-Omicron era, which could then be compared to seroprevalence data in smaller cohorts and adjusted accordingly. I don't really see the point in discounting imperfect, what he calls brain dead, pieces of the puzzle. Let's look at all the evidence and appraise it appropriately. But again, our study is not risk-benefit evaluation, but a signal detection study which showcases a global network approach. Best regards, Anders. So what you're hopefully seeing in this case is that Vinay, a lot of times, is putting out criticism that is not actually relevant to the study. He continues to call it a risk-benefit analysis when it's very clear that the paper was not a risk-benefit analysis. And when he does offer reasonable criticism, he hyperfixates on it. And that's really what Anders is getting at in that last comment. Because the study is not perfect, and no study is perfect, Vinay is really focusing and zooming in on those imperfections while seeming to ignore the big benefits and strengths that the study brings. It's true that a study like this is not really getting at a question of risk-benefit, but it does get at the question of how widespread are these problems and what problems should we be focusing on? And the answer, which again is in line with several research papers that have come before it, is that the vaccines do have some rare risks, but they're not huge. They remain rare and mostly associated with the initial dose. This runs counter to claims of anti-vaxxers who for years now have been saying that COVID vaccines have been killing so many people, maiming so many people, and even people like Brett Weinstein who say that millions of people have been killed by vaccines. Data like these show that that is impossible. It also offers very useful epidemiological data as to where we can focus our efforts in investigating further these adverse events. And in science, repetition and replication of data is always useful. So this is a very useful study that had a lot of work put into it. And for him to just disregard all of that and call it a brain-dead study is not only insulting, but really dishonest and kind of plays into what his audience wants to hear. Because most of Vinay's audience are anti-vaccine. Now let's move on to this study of 46 million persons in the UK. Again, I know he's going to say I'm not an epidemiologist by training, so I don't know what I'm talking about, but I did consult an epidemiologist to make sure that what I'm saying in this video does make sense. So let's talk about what this paper is, Vinay's comments on it, and what the evidence actually says about his comments. This is a study looking at longitudinal health records from 45.7 million residents in England. In contrast to the United States, England has a very different healthcare system, which means that its health record system is more unified and better recorded. So these health records are a powerful tool when doing epidemiological work to get at questions of adverse events rates in a given population from a particular drug or vaccine. And they use this data to look at the rates of thrombotic, in other words, blood clotting, or cardiac events following COVID vaccination in this population. They use a regression analysis to get adjusted hazard ratios for each event that they look at, and they're able to adjust for several confounders within this data set. Confounders are simply things that you're not directly measuring but can affect your results. For example, if I do a study of, I don't know, what's an old people cereal? Grape nuts. Okay, so if I do a study of people who eat grape nuts and measure how many more years longer they live, and I find that people who eat grape nuts are more likely to die within the next 10 years, age is a big confounder in that context. Because if most of the people eating grape nuts are 70, then they're going to be more likely to pass away within the next 10 years than, say, a 15-year-old who eats Frosted Flakes. That's just a crude example of what a confounder is. So in this case, they do control for a lot of confounders like age, sex, and socioeconomic status. You can find a list of all the confounders that they adjusted for and the associated data tables in the supplementary data and in this paragraph here. But it's important to recognize that not all confounders can be accounted for, and they are very clear about this in their limitations section. And they do perform an impressive number of subgroup analyses adjusting for different confounders. One of which that I mentioned earlier was measuring the rates of myocarditis before and after the CDC announcement that myocarditis can be caused by mRNA vaccines. And they did see that there was an increase following the announcement. That's not to say that all the myocarditis cases are because of panic or influence from a media announcement, but it does show that it can affect those things. So again, what this study ended up showing is confirming what we already know, that blood clots are associated with certain types of COVID vaccines, and myocarditis is associated with certain kinds of COVID vaccines, and that these events are relatively rare. And what it also showed again is that these conspiracies that vaccines are killing millions of people pushed by people like Brett Weinstein are impossible to be true. So with all that said, let's get into what Vinay said about the paper and what the evidence says in response. So in Vinay's video about this study, he points to confounders as being reasons why these data are bad. He points to the Societal Deprivation Index, which show that unvaccinated people are more likely to be of lower societal status, and smoking, which showed that unvaccinated are more likely to smoke. He says that these confounders were not properly dealt with, and that they work toward invalidating any conclusions you can make about safety from these vaccines. The idea being that adverse events hide in the vaccinated group because the unvaccinated group are less healthy to begin with. But in the study, they do include socioeconomic status and smoking as confounders that they account for. For socioeconomic status, he points out that this could have been accounted for better, and his point there, I think, is reasonable. But for smoking, they do account for that. They do an analysis of smoking status broken down by current smoker, former smoker, never smoking, and information missing. But he's definitely doing some cherry picking here because when it comes to confounders, it works both ways. The vaccinated group also has these kinds of confounders. For example, people who are vaccinated are more likely to be elderly and have more comorbidities, which are arguably stronger confounders for cardiac events in this case. But he doesn't mention those. He just focuses on confounders that only work in one direction. There's also valid criticism here that using a Cox regression model isn't necessarily the best way to analyze this data, but it's a perfectly fine way to do it. But with all that said, what Vinay is really harping on in his video is this finding that the vaccinated group had about a 30% less risk of suffering cardiac events, like heart attacks, than the unvaccinated group. I think most reasonable people, including myself, look at this result and we don't immediately hang our hat on it and say, yes, the COVID vaccine is going to reduce your risk of having a heart attack by 30%. I think there are some confounders there that are pushing that number lower. Again, the main takeaway from a figure like that is that it's impossible that vaccines are causing massive excess deaths and killing lots of people. In order for those wild anti-vaccine beliefs to be true, it would have to be that the baseline rate of cardiac mortality or cardiac events in the vaccinated group is 50 to 60% less than the unvaccinated group at baseline, in which the vaccine would have to then raise that risk by 10 to 20% in order for these excess death claims to be even remotely true. But that assumption is beyond unreasonable. The next thing Vinay says is an example of a reasonable thought taken way too far. He basically says that he would want to see negative control outcomes, meaning in the unvaccinated and vaccinated group, do events that are not affected by the vaccine take place at equal rates? Like, do car accidents happen at equal rates in both groups? Does breast cancer happen in equal rates at both groups? That's not something these authors did, and that would be useful to have. But in his words, he says that them not doing this is, quote, shitty editorial practice, unquote. This is not only rude, but inflammatory to a lay audience. When he uses such strong language, it gives the impression that this paper was useless and that the authors really didn't know what they were doing, when that could not be further from the truth. It's just a really dishonest and inaccurate way to communicate the science. But he says it because he knows his audience is going to like it, because he knows his audience is mostly anti-vaccine. And in terms of internal controls in the study, we do know that myocarditis and rare blood clotting disorders are associated with different types of COVID vaccines. And those did show in this study. So while there aren't negative control outcomes, there are positive controls built into the study that register valid as positive controls. That means that because we see those events increasing in this given population, we should also see other true events increasing in this population. The last claim that Vinay makes in this video that he has about this paper is in regards to, again, a risk-benefit ratio with COVID vaccines and young adults or young men. He says that he has proven that COVID vaccines have a higher risk of myocarditis among young men than any risk that COVID could ever pose to them. This, of course, gives the impression that young men don't need COVID vaccines and that COVID vaccines are in fact more harmful to them than the virus itself. And that is just not true, and where we start to get into territory of him being really unreasonable. When it comes to COVID deaths, there have been almost 2,000 children below the age of 18 in the US that have died from COVID in the last 4 years. For comparison, an average flu season kills about a couple hundred children each year. Not really close to what COVID has done. That's 2,000 kids gone. And is that number relatively low compared to the total number of kids in the US who got COVID and survived? Yes. But that's still 2,000 kids that could have been saved by a vaccine. Let's look at hospitalizations. According to the American Academy of Pediatrics, about 234,000 children under the age of 18 were hospitalized with confirmed cases of COVID-19 from the fall of 2020 to the spring of 2024. A child getting hospitalized is not good. It's much more traumatic than wearing a mask, Vinay. It's something we want to prevent. And 44% of the child hospital admissions occurred in the South, which has 39% of the U.S. childhood population. And the South in the U.S. had relatively lower vaccination rates than other regions. There's also extensive study of risk-benefit analysis of vaccines in younger age groups. I've compiled them all in a reference manager that I'll link in the description below. The folder that these studies are in, you can see on the screen here. And what is consistent throughout all of these studies is that the myocarditis cases that we see occurring in young men following COVID vaccination tend to be mild and self-resolving. In other words, they don't have serious complications, they don't have lasting complications, they are generally normal after a few days. Meanwhile, COVID has consistently been shown to have a greater risk to this age group. They're more likely to suffer more serious forms of myocarditis, and they're more likely to suffer other things like multisystem inflammatory syndrome. They're more likely to experience pneumonia. They're more likely to, yes, die. So I just don't see it as at all reasonable to say that children have more risk posed to them with COVID vaccines than they do with a full-fledged virus. And I do think this extends to boosters. I don't think there's any convincing evidence to say that boosters pose more risk to a child than a full-fledged virus. However, there is a reasonable discussion we can have on whether or not children need boosters in this day and age. The first 2 doses in the original mRNA vaccine series did provide a lot of really good protection for children against severe outcomes of SARS-CoV-2. And nowadays, a single updated shot, which is what's recommended by the CDC, does that job pretty well as well. So if you want to know my stance, I think that the evidence is pretty convincing in showing that boosters don't really carry that much risk, and they do confer some marginal benefits past the initial series. And that's specifically to younger, healthier age groups. Older age groups or people who are more at risk, the story could be completely different. They might benefit much more from those boosters than someone else. Again, there's a reasonable discussion to be had here, but Vinay, again, takes it too far and says that children should not get vaccinated. In fact, he said that many times. Lastly here, I just want to include this because he did say it in his video.
The last thing I'd say is I see that there's a few, like YouTube accounts where there are people who claim to debunk misinformation or communicate science, and then they say, I have a PhD in biology or something like that. But they're unemployed. I mean, they don't actually work as a professor at a university. They don't publish papers. PubMed these people. If you haven't published 10 papers in the last year, you might have been a scientist, but are you still a scientist? I don't know what the hell you are. You're out of the game. And if you're not published more than 100 or 200 papers, and if you're not published like 100 papers in epidemiology or 200 papers in epidemiology, you probably don't know a lot about how to read and dissect and think about papers, which is most people just debunking. It's one thing to have an opinion. I think everyone's entitled to an opinion. But if you claim you're debunking someone and you are an idiot, which is what a lot of these people are, then I think it's a problem.
Apparently, a few people think that he's talking about me in that clip, which if he is, kind of shows that he's not really doing his research. I am employed. I have a full-time job in science. It's just not in academia, so my job is not to publish papers. But I'm very much still in the game, as he calls it. I'm still very much doing science every week. And Vinay talks this talk. He'll talk really rudely about people's papers online, but when it comes to actually interacting with them, he just blocks them. In fact, he has blocked hundreds, if not thousands, of people on social media who just disagree with him. You don't even necessarily have to directly engage with him. He just blocks you. So trying to discredit me, Vinay, by getting facts wrong about me is kind of weird.
But don't tell no lie about me, and I won't tell truths about you.
On March 30th, 2021, when 547,309 Americans had died of COVID, Vinay Prasad said, and I quote, "Perhaps COVID-19 is winding down. This summer, when cases fall, when vaccination grows, put down your iPads and phones and meet people in real life." The COVID death toll would go on to almost double. I'm glad I didn't try to shame people into foregoing public health precautions. On June 23rd, 2021, when COVID had killed 598,895 Americans, Vinay Prasad said, and I quote, "First, let us all remember cases are, in all caps, falling precipitously. The raw number of adolescent cases is the point that is falling. The actual numbers show both COVID and multisystem inflammatory syndrome cases is plummeting with adult vaccination. Children and adolescents would go on to have their worst few months of hospitalization and death from COVID when the Omicron wave hit in winter of 2021 and 2022. I'm sure glad I didn't downplay children's suffering. There's a lot more in this book. I highly recommend it, but I'll just end with this one here. Vinay Prasad authored an article entitled How Democracy Ends. COVID-19 Policy Shows a Potential Path to the End of America, in which he said, and I quote, "When democratically elected systems transform into totalitarian regimes, the transition is subtle, stepwise, and involves a combination of pre-planned as well as serendipitous events. Indeed, this was the case with Germany in the years 1929 to 1939, where Hitler was given a chance at governing. The president subsequently died, a key general resigned after a scandal, and the pathway to the Führer was inevitable." I'm really glad I didn't use the Holocaust to try to scare people about public health measures. Holy cow. Well, I think there's not much more to be said there. That is who Vinay Prasad is. I don't think he's a reasonable guy. I don't think he's been reasonable in much of the pandemic. He says some reasonable things and makes some reasonable recommendations to data, but then takes it way too far in order to appeal to his audience of anti-vaxxers. In my opinion, you're going to want to listen to other communicators who are going to more accurately and honestly inform you on what the data say, especially when the next pandemic comes, because we know there is going to be another one eventually. They're like earthquakes and hurricanes. They are going to just happen, and we have to be ready for them. And if you want to be properly informed when they do happen, I recommend not listening to Vinay Prasad. That's my opinion, and you can read the data for yourself. Let me know what you think. That's going to do it for the last video of Debunking Week. As always, all of the science that I talked about in this video are linked in the description below so that you can check them out for yourself. And don't just listen to me, listen to other good science communicators and epidemiologists as well. I'll have some recommendations also linked in the description. And if you enjoyed this video, then don't forget to subscribe so that you can join me next time where I'll be debunking some more funky stuff. See you then.